Whether you're designing your very first study or you're just looking to refine your clinical trial methodology, mastering how to define, manipulate, and measure your variables is the absolute bedrock of valid scientific inquiry. We're going to take a measured, methodical approach today to make sure every single concept is perfectly clear. Let's get started.
Here is our roadmap for today. First, what are research variables? Second, cause and effect relationships. Third, selecting your study outcomes. And fourth, practical steps for implementation.
Section 1. What are research variables?
In clinical terms, a variable is simply a measurable characteristic or event that takes on different values. Essentially, it's the entity that's going to change and be systematically observed throughout your research. But here is the crucial part. A variable must be directly linked to the objectives of your study. You literally have to list all the variables you intend to study, and you even need to be prepared to justify why certain baseline factors are intentionally being left out of your protocol.
Now, as a researcher, you have to properly categorize your variables so you can determine the correct statistical measurements later on. Broadly, we divide these into two camps. First, we have qualitative or categorical variables. These can be ordinal, meaning they have a set order, like ranking the severity of heart failure from mild to severe. Or they can be nominal, meaning they are just named categories without an order, like gender. Then we have quantitative or numerical variables. These break down into continuous variables, like a patient's exact body weight or height, and discrete variables, which are countable whole numbers, like the exact number of hospital admissions a patient has experienced.
Okay, pay really close attention to this next concept, the irreversible conversion rule. You can safely categorize continuous quantitative variables into qualitative groups. For instance, you could group exact numerical body weights into categorical ranges like normal, overweight, or obese. But, and this is a massive but, you cannot reverse this process. Once you collect data as a category, you can never, ever extract the exact numerical value back out. So, as a rule of thumb in clinical research, always collect your data in its most precise, quantitative form whenever you possibly can.
Section 2. Cause and effect relationships.
The fundamental dynamic in any research is cause and effect, right? And this relationship is driven by two distinct roles. First is the independent variable. Think of this as the dominant factor. It's the intervention or the exposure that you, the researcher, manipulate or observe. It influences other factors. Second is the dependent variable. You could think of this as the submissive factor. It's the outcome you're actually measuring, which is directly influenced by changes in that independent variable.
To ground this in a real clinical setting, just consider a patient's core body temperature. If the temperature rises, it acts as the independent factor, which directly influences and alters the patient's heart rate. The heart rate, therefore, is our dependent variable. Similarly, a factor like gender might act as an independent variable affecting certain psychological outcomes. The independent variable is what dictates the action, while the dependent variable provides the measurable reaction.
Section 3. Selecting your study outcomes.
Before you can measure a study's effectiveness, you have to clearly contrast your outcomes. And as a general rule, the fewer outcomes, the better. Your primary outcome is the single most relevant variable to answer your main research question. It literally determines whether your trial is a success or a failure, and it dictates the statistical power and the sample size for your entire study. Secondary outcomes, on the other hand, are your additional endpoints. They provide really necessary supporting evidence. For example, if your primary outcome is mortality, a great secondary outcome might be readmission rates. But you have to interpret secondary outcomes with great caution. Why? Because monitoring too many of them significantly increases your risk of statistical noise and false positive findings.
Sometimes, though, a single primary outcome just isn't enough to capture the full clinical picture. And that's where we use what's called a composite endpoint. In our source literature, we look at a trial for pulmonary arterial hypertension. Because severe events in this condition are relatively rare, the researchers combined multiple correlated variables, specifically time to first worsening of symptoms, need for lung transplant, and death, into one single composite primary outcome. Doing this increases statistical efficiency, allowing the study to actually achieve sufficient power. But be warned, there's a catch here. If your intervention only improves one minor component of that composite, it can misleadingly make the entire composite look statistically significant.
Section 4. Practical steps for implementation.
Let's consider a practical clinical scenario. Imagine you're tasked with designing an observational study to answer a very specific question. What is the prevalence of anemia in secondary school children? Take a moment to think about that. How exactly would you classify and structure the variables for your research protocol?
Well, As mapped out in our source literature, you have to systematically categorize every single factor. First, you define the socio-demographic variables, the age, gender, and family income of the students. Next, you establish other baseline factors that might influence your results. Things like dietary habits. Do they eat fast food or are they vegetarian? Then, you explicitly state your primary dependent variable. In this specific case, it's the precise hemoglobin level, measured in milligrams per deciliter. Finally, you list your secondary outcomes, which might include serum iron levels or red blood cell morphology. This is exactly how you transform a broad question into a rigid, measurable framework.
It is absolutely vital for patient-centered research. MCID stands for the minimal clinically important difference. First described back in 1989, it represents the smallest difference in a clinical score that the patient actually perceives as beneficial, prompting a change in their management. Why does this matter so much? Because a drug might create a measurable change in your dependent variable that achieves statistical significance with a p-value of 0.04. But if that change doesn't meet the MCID threshold, the patient will literally feel no improvement. Your research must always strive for clinical relevance, not just statistical success.
As we wrap up this explainer, I want to leave you with a challenge for your very next study design. I want you to look closely at your protocol and ask yourself, are your chosen variables truly answering your primary research question, or are you just chasing statistical noise at the expense of real patient outcomes? Because a study with flawed variables isn't just bad math, it's a failure of our clinical duty. Focus your aims, define your variables rigorously, and ensure your outcomes actually matter to the patient. Thank you for joining me for this session, and I wish you absolute clarity and precision in your future clinical research.